Hello, everyone on YouTube. Welcome to today's session. We'll be starting shortly.
Good afternoon, everyone. This is Dr. Simapreet Sandhu, Secretary General, Asian Society of Oral and Maxillofacial Pathology. On behalf of the Honorary President, Dr. K. Ranganathan, I welcome the Asomp advisors, Professor Tilak Ratne and Professor Roshna Zan, counselors from all parts of Asia, presenters from 3 countries, Malaysia, India, and Sri Lanka, and everyone who's logged in today to be with us. This is for the first time that Asomp is organizing the CPC, which is the Clinical Pathologic Correlation Series 2022. And now I welcome the President, Dr. Ranganathan, to open the session. Welcome, Dr. Ranganathan. So you're muted.
Very, very good afternoon to you all. Thank you, Dr. Simapreet. Let me welcome you all to the first series of CPC being conducted by the Asian Society of oral and maxillofacial pathology. Am I audible? Is that okay?
Yes, sir.
Awesome. All right. Let me first thank the advisors, Dr. Zain and Dr. Tilakratne, for having initiated this process. Dr. Simapreet Sandhu for having, pinned me down and made sure that, I take an active part in calling all the members and the presenters. Dr. Mandana, of course, as ever, very helpful. Thank you, Dr. Mandana, for having set up the streaming platform. Thank you very much. Let me thank all the members who have joined here. And last but not the least, the presenters from Malaysia, India, and Sri Lanka for having made this possible. I'm sure we're going to have a fantastic round of discussion here with the senior members and all the other members. So without much ado, let me hand it to Dr. Simapreet to initiate the proceedings.
Now we welcome, we have 6 presenters and 2 experts. And we are very lucky to have our own president, Dr. K. Ranganathan, who's agreed to be the advisor, along with Professor Tilak Ratne, the advisor Asomp. These are 2 experts. And though they don't need any introduction, but I'll still do the customary introduction for both of them. Dr. Kanan Ranganathan is professor and head, Department of Oral and Maxillofacial Pathology at Raga's Dental College, Chennai. He's a fellow American Academy and Indian Association of Oral and Maxillofacial Pathology, President, Asian Society of Oral and Maxillofacial Pathology, Asomp, President and Secretary of Indian Association of Oral and Maxillofacial Pathologists, Secretary, International Association of Oral Pathologists. He's the Chairperson, Fellowship Committee of Indian Association of Oral and Maxillofacial Pathology. PhD Guide at the MGR Medical University, Sri Ramchandra University, Sri Balaji Vidyapeeth University, Savita University, and has about 164 publications and contributed to 5 textbooks. Welcome, sir. And the next expert is Dr. Professor W.M. Tilak Ratne, who's a professor, Department of Oral and Maxillofacial Clinical Sciences, Faculty of Dentistry, University of Malaya, Malaysia, and Department of Oral Pathology, University of Virginia, Sri Lanka. Amongst his many professional qualifications, he has done his qualifications from United Kingdom and PhD from Japan. He has been working as an oral pathologist for over 3 decades. He's past president of International Association of Oral Pathologists, professor of oral pathology at Queen Mary University of London, former dean and senior professor of oral pathology, Faculty of Dental Sciences, University of Virginia, Sri Lanka, published over 150 papers with a H index of 35, and written a textbook, editorial board member for the latest WHO classification of head and neck tumors, and expert member of Oral Cancer Prevention Handbook by AARC. And today's connector is our moderator, and we all know her, Professor Mandana Donahue, an oral and maxillofacial pathologist and a Asomp counselor from India. 2 years ago, she founded Oral Pathology 360 and has since then taken virtual learning and connecting in oral pathology and related disciplines to a previously unimagined level. We are glad to have the benefit of her expertise gained while hosting over 150 sessions in the last 2 years, and today she is running the Asomp platform for us. Thank you so much. Welcome, everyone. And I also welcome the 6 participants from the 3 countries. Over to Mandana now to take the session forward.
Thank you, Dr. Simapreet, and thank you, sir. It's truly a pleasure and a privilege to be involved with this. And I think now, without any further delay, and let me just start. So, one small bit of announcement for everyone on YouTube. Please share your questions, your thoughts, your comments in the chat, and do so as you think of them, because there's a little time lag between us and you in YouTube, about 30 or 40 seconds. So when we reach the question session, you may still not be at the questions. So it's better that you share your thoughts as you think of them. We will share them as in the order that they appear. With that, let's start with our first one, that is Dr. Lavanya. And let me add her to the stream. Right. Dr. Lavanya, you can start.
Yeah, thank you for the opportunity and good afternoon to everyone. I'm Dr. Lavanya from Raga's Dental College and Hospital to present a case in the swelling in the buccal mucosa. So, this is a 62-year-old male patient who had a painless swelling in the left cheek region for about 4 months and 5 into 4 centimeter in size, soft in consistency with no pus discharge. And this was the clinical picture which was taken at the time of biopsy. And the CT scan showed a well defined soft tissue lesion in the left buccal mucosa. So with this, we go to the differential diagnosis. As there was no sign of inflammation, we could rule out the reactive lesions and we could move to soft tissue tumors in this area, such as adipocytic, vascular, smooth muscle tumors, nerve sheath tumors, and salivary gland tumors. So the grossed specimen, which was well defined, gray to white in color, and we did a cut section. We did it into two sections, and the cut surface showed a white, dense interior. So now looking into the histopath features, what we could see is a cellular neoplasm with an array of ovoid to spindle-shaped cells and with prominent vascularity. The spindle-shaped cells were closely arranged in some areas and loosely arranged in other areas. To go into a closer view, we had these spindle-shaped cells arranged in clusters in a eosinophilic connective tissue, and thin-walled blood vessels were also seen. The collagen fibers were also hyalinized. Under high power magnification, the spindle shaped or the polygonal shaped cells showed a little or very sparse amount of cytoplasm with a vesicular nuclei and indistinct cell boundaries. So, with all these histopath features, we could give a differential diagnosis for a fibroblastic tumors in this area, which could be, these are the lesions, commonest lesions that can occur. One is the spindle cell lipoma, and all these lesions will have the spindle cells arranged as fascicles or storiform or cellular pattern. I just mentioned a few of them. The spindle cell lipoma with fascicles of spindle cells and adipocytes in a myxoid stroma. Fibrous histiocytoma with storiform spindle-shaped cells with stromal hyalinization. Synovial sarcoma, fascicles, uniform, spindle cells, branching vessels, and stromal hyalinization. Dermatofibrosarcoma protuberans. It again has fascicles, whorls of uniform spindle cells in a honeycomb appearance. Next was solitary fibrous tumor. It could be patternless spindle to ovoid cells with branching staghorn shaped blood vessels. And malignant peripheral nerve sheath tumor. It has hyper and hypocellular spindle cells, blood vessels, and increased mitosis. With these are all the histopath features which are similar appearance. Apart from this, we have IHC profile for these fibroblastic tumors. Two of them are most important. One is CD34, the other one is STAT6. Most of these tumors are CD34 positive except for synovial sarcoma and malignant peripheral nerve sheath tumor, which had EMA and S100 positivity. Coming to the IHC negative marker, STAT6 is the most predominant among these tumors, except for solitary fibrous tumor, which is STAT6 positive. So, with all this differential diagnosis, when we look once again into our lesion, we could see the acellular and the cellular regions showing a patternless pattern, and the thin wall dilated blood vessel showing a staghorn appearance. We also had IHC profile for this lesion, and it was STAT6 positive. And finally, we could give a diagnosis of solitary fibrous tumor for this lesion. So it is a tumor of fibroblastic differentiation in the fifth edition of WHO and previously called as hemangiopericytoma. Histomorphologically, these two represents the two ends of a single entity before the molecular profiling. This lesion has NAB2 STAT6 gene fusion, resulting in inversion of chromosome 12q13. And they have some malignant component also. For that, the risk stratification score, such as the low, intermediate, and high, helps to identify the malignant potential and recurrence. So, to summarize, solitary fibrous tumor are a rare sarcoma subtype. They can occur at any anatomical site. The key to identify is the hallmark NAB2 STAT6 gene fusion, surgery with or without radiotherapy. That is the standard of care for any localized disease. And thank you for the opportunity.
Thank you, Dr. Lavanya. Um, Dr. Tilak?
Yes, I think Lavanya, it's a good case.
Yeah.
It's a nice case. But did you do other markers like CD34, CD99, BCL2,
Yes.
etc.?
Yes, sir. Yes, sir. Most of them were negative. Only the STAT6 came as diffuse positive.
So
CD99 and all the others, BCL2, all came as negative.
the large majority of SFTs can be positive for these
Yeah,
markers,
yes, yes, sir.
CD34, CD99, BCL2, etc. They are completely negative, right?
Yes,
No,
they are
Tilak, what
actually able
happened?
to detect.
No, I'll just intervene. What happened was
Mhm.
we didn't have the IHC profile in our lab, so we sent it to one of
Right,
the specialty centers. They, the general pathologists, and we spoke to them, and they narrowed it down and said, let's just do because the pattern was pretty classic.
right,
Let's just do the stat six, and I think we pretty much decided to stick with that on routine special stains actually.
right.
Yeah. So, this was, I think, one of the few cases which was classic. So there was no question of any, overlap.
Mm.
Uh, of course, there are a few tumors which can be STAT6 positive, like your dedifferentiated liposarc and pleomorphic sarc. But we thought the pattern was pretty, definitive not to go in for the panel. And this was done out of interest because the patient could not afford to have the stain done actually. So I think
Mm.
it would have been interesting to see what the other stains were, but that would have been nice actually.
Yeah. And also the when you describe the histopathology, I think it's better to include myofibroma also as a differential
Yes.
Yeah.
because
Yeah.
you
Yes.
said there are hypocellular and hypercellular
Yes.
areas
Yes,
and
sir.
the
Yes.
vasculature, those are the features of
Yeah.
myofibroma as well.
Yes.
SMA was also not done, right?
Yeah,
No,
sir.
no, no.
Yes. No,
With the
no,
your
no.
STAT6 is convincingly positive actually.
Yeah, this was actually referred to me from outside. It was an extramural case. Uh,
Right.
so I had to sort of send it off for special stains actually. That's a good point. Like, thank you very much.
Yeah, nice case.
We have one question from Dr. Kirti. What is the recurrence rate? Did you follow it up?
Actually, this is a benign lesion. Actually, benign lesions never has that much of a recurrence rate. But when you look for the malignant potentiality of this lesion, such as the necrotic areas, the mitotic figure, it's about 10 to 15% chances of having a recurrence in a malignant tumor of solitary fibrous tumor. Anyway, this is a benign lesion.
That seems to be it. There are no other questions. Shall we go on with the next
And
presenter?
one last comment. It's good
Yes, sir.
Lavanya mentioned about, in the past we used to call it hemangiopericytoma,
Yeah.
but we need
Yes.
to remember the fact that, SFT hemangiopericytoma is a spectrum.
Yes.
And true hemangiopericitomas occur in the sinonasal area.
Yes.
Sinonasal
Yes.
hemangiopericitoma is considered as a true entity,
Yes.
but other areas it is the spectrum of SFT.
Solitary fibrous tumors.
Yeah. Okay.
Okay, thank you, Dr. Lavanya, and thank you everyone for the comments. Now we shall go on with Dr. Feroz Rahman is our next presenter, and right, you can please start.
Okay, thank you, Dr. Mandana. Hi, good afternoon, everyone, especially to our expert, Prof. Tila and Prof. Ranga. So today I'm going to share a case. I think this one is more to oral medicine, but I still will cover oral pathology part, histopathology part. Okay, this is the first time I encountered this case in my clinic. So let's begin. Okay, this is the patient detail, 29 years old female, presented with gum swelling with duration of 5 weeks. It was rapidly growing, painless, no discharge, no bleeding. Okay. This case was referred from periodontal specialist clinic. Medically, patient is anemic on hematinic, otherwise unremarkable. On general condition, patient came to our clinic with her father and on wheelchair. Patient was very weak and pale and fatigued. Okay. And this is an extraoral examination. Skin looks pallor, and then there's a multiple small nodular skin lesion, acne-like, all over her face, scalp, and neck. It was soft to firm consistency, and patient claimed the lesion, cutaneous lesion started at about the same time with gingival lesion. Okay, and then there's a regional lymphadenopathy, submental and submandibular lymph node was palpable, but it's not tender. Okay, intraoral examination, there's generalized gingival swelling, all quadrant. It was firm and non-tender. Color, mostly mucosa colored, with some areas with slight reddish. Okay, dentition unremarkable. Okay, this is OPG. Orthopathogram show no evidence of bony involvement. Okay, based on the clinical presentation, this is my differential diagnosis. Uh, Common thing come first. So chronic inflammation can cause enlargement because of the edema and also fibrosis. And then drug-related gingival hyperplasia is very common in gum. Uh, Unfortunately, our patient not taking any medication. And orofacial granulomatosis, 25% of OFG cases are presented with the gum lesion, gingival involvement. They call it granulomatous gingivitis. And then gingival fibromatosis is a progressively gingival enlargement, but this one usually manifests in the childhood. Okay, and then neoplastic infiltrate like lymphoma and leukemia is common in the gum and other tumor. Okay, this is investigation that we've done because we plan to do a biopsy on the gingiva, but we send patient because patient is very weak and pale, so we send patient for the baseline investigation, and then the result came up with a red flags because white blood count is 212, is very high, with the low RBC and hemoglobin, and platelet count is also very low. So we suspect patient is having hematological disorder, so we refer patient to hematology clinic, and then they did a further investigation. They did peripheral blood smear and also bone marrow trifine. It's confirmed that leukemic cell in the bone marrow and peripheral blood. So patient diagnosed with acute myeloid leukemia, and 5 means a monocytic differentiation. Okay, and then because of the patient presented with the cutaneous lesion, we refer patient to dermatology clinic also for skin assessment. Okay, and then biopsy, this one biopsy taken from right cheek. Okay, from this photomicrograph, okay, from low power, we can see there's a diffuse infiltration of red small round blue cell, okay, within the dermis and also up to subcutaneous area. Okay, and from this photomicrograph, you can see there's a green zone. Okay, it separated the overlying surface epithelium and also the neoplastic cell infiltrates. Okay, in this photomicrogram, we can see the neoplastic, sorry, the malignant cell are medium to large in size, with irregular nuclear contour, and the tumor cells also show high nuclear to cytoplasmic ratio, fine chromatin, and occasional conspicuous nucleoli. Okay, and immunohistochemical studies show that the tumor cell show patchy strong positivity with myeloperoxidase, but negative for CD3, CD20, CD117, CD34, TDT. Okay, and Ki67 show high proliferative activity with more than 90%. Okay, so final diagnosis is a generalized leukemic gingival enlargement and cutaneous leukemic cutis, and is associated with the underlying acute myeloid leukemia. Okay, so after the induction chemotherapy, this is how patient looks like. Okay, cutaneous lesion has resolved completely, as well as the gingival enlargement. Okay, so just a brief about leukemia. Leukemia represents a range of malignancy that arise from white blood cell precursors with a worldwide incidence of 3.7 per 100,000 person and age-dependent mortality of 2.7 to almost 18 per 100%. Leukemia account at about 4% of all death from malignancy. The etiology of leukemia is poorly defined. Okay, it can associate with the chemical injury, radiation therapy, viral infection, and others. And then leukemia are usually classified according to their histogenesis and clinical behavior. Okay, acute leukemia mostly in the children, while chronic leukemia in the adult. So oral manifestation of leukemia can be secondary or primary. Okay, secondary to marrow failure and cytopenia, like anemia, we can see in patient oral mucosa pallor. Neutropenia, patient have tendency to get infection and non-healing ulcer, and then thrombocytopenia, patient can have a petechial hemorrhage of the soft palate, easy bruising, and gingival bleeding. Okay, leukemic infiltration to oral soft tissue, extramedullary leukemia. Patient can present it with the tumor-like lesion. We call it myeloid sarcoma, or the classic one is a gingival enlargement, like what we are seeing today. Okay, and then leukemic gingival enlargement is more common in acute than chronic leukemia in adult and in people with a leukemia and subleukemic form of leukemia. Okay, it's most commonly seen with the acute myeloid leukemia subtype, acute monocytic leukemia M5, about 66.7%. Okay, like similar like our case today. And then acute myelomonocytic leukemia M4 18.5%, and acute myelocytic leukemia M1 to M2 3.7%. Okay, leukemic gingival enlargement is not observed in adulterous individual. This suggests that local irritation and trauma associated with the presence of teeth may play a role in the pathogenesis of this abnormality. Okay, it usually resolves completely or at least partly with effective chemotherapy, and gingival manifestation is not considered to be predictive of poor outcome. It is usually the early sign of the disease that lead to a diagnosis of leukemia. Okay, leukemic cutis characteristically demonstrate the infiltration of the skin by neoplastic leukocyte. The clinical appearance of LC are highly variable. It may present with nodular, plaque, macule to erythematous rash. Okay, leukemic cutis occur in 5% with CML, chronic myeloid leukemia, and 8% with CLL, and 10% with monocytic leukemia. Myeloid leukemia with monocytic differentiation more commonly involve the skin than other type of myeloid leukemia. Okay, leukemic cutis is relatively rare and typically signify an aggressive behavior and advanced disease stage. Okay, leukemic cutis in patient with AML is associated with decreased overall survival and leukemic specific survival. Okay, which require more intensive treatment and regular monitoring of their leukemic disease. Okay, so this is as I said earlier, leukemic cutis is highly variable. Okay, this is the most common presentation. Usually it's present as papule, macule, or plaque with erythematous discoloration. Okay, the site is not specific. It can be anywhere on the skin. Okay, as conclusion, leukemic gingival enlargement is usually presenting as early manifestation of acute myeloid leukemia. However, it is not associated with poorer prognosis. Okay, in contrast, leukemic cutis in patients with AML is associated with aggressive behavior and decreased overall survival and leukemic specific survival, which may require more intensive treatment. Okay, to add in early diagnosis and subsequent early management of patient, oral healthcare professionals should be aware of the mucocutaneous manifestation of systemic disease and proceed with investigation and refer to the higher And the high mobility and mortality of leukemia in advanced stage emphasize the necessity for reliable communication between involved interdisciplinary team and the need for integrated management. Okay, I would like to thank my colleague here, Dr. Sarabana Gopalan and others, and this is my reference. So with that, I thank you.
Okay. Thank you for this very, very interesting case.
Yeah,
That's nice. The K67 was pretty high, almost 90%.
it's more than 90%, Prof. Yeah.
Yeah. Did you know uh, what percentage of the circulating cells were MPO positive? Did you have any
Uh,
idea about that?
the peripheral blood smear, I think the blast is about 24%. The
Okay.
prono site is 8%, something like that, Prof.
Yeah. See, because there has been a suggestion that the percentage of blood cells which are MPO positive in the circulating blood is closely tied up with prognosis, and there's that one sort of correlation we talk about actually. But however, given the fact that the KI index is so high, how did the patient do eventually? Do you have a follow up of the patient? Or?
Oh yeah, I just seen the patient recently because patient complete the induction chemotherapy in somewhere in February, and then patient in remission state for the past 7 months. Then this month patient relapsed,
Oh,
and then
okay.
yeah, so they need to
All right.
start another chemotherapy.
Thank you, Dr. Tilla.
So I think you're on mute.
Dr. Tilak, I think it's muted.
Yeah, sorry. Yeah,
Unused.
no, I was telling it's a good case virus, and myeloid leukemia presenting in our soft tissues, as you correctly said, we call myeloid sarcoma. Or another
Yeah,
name that we use is chloroma.
chloroma, yeah.
Chloroma, because of the color of the lesion. It's because of the myeloperoxidase. It gives green color
Oh, yeah.
to the tumor. So other than the gingival involvement, I think the common site in the oral cavity is tongue. If you have uh, a tumor that you can't give a name with cells similar to what you described, I think myeloid sarcoma should be included in the differential diagnosis. It's a good case.
Yeah. Thank you, Prof.
Right. There are no more questions that I can see anywhere. So I think we can go to the next case. Thank you, Dr. Feroz. That was a nice presentation. So our next presenter is Professor Samadura Srivardhane. And let me add her to the presentation. Right. Professor Samadra, you haven't shared your presentation.
Sorry.
Yeah. Okay. So, right.
Good afternoon, everyone. Today I would like, so I'm Professor Samudra Sirivardhana from the Faculty of Dental Sciences, Peradeniya University. And I would like to present a case on a painless pharyngeal nodule. About the case, this patient presented with a nodule in the pharyngeal area. He's a 66-year-old male, and this patient was having multiple skin nodules. That was confirmed as neurofibromas. So this patient was suffering neurofibromatosis. And this patient complaint was difficult in swallowing. And because of that, the history, the clinical investigations was done, and then there was a 5 by 3 by 3 centimeter sized reddish pedunculated mass on the pharyngeal wall. Because of the history of the patient, so the surgeon's clinical impression was neurofibroma. Unfortunately, I don't have a clinical picture because they have excised, and we received only the biopsy sample. And microscopic specimen we received was about 3 by 3 centimeters of nodule. And we prepared the slides, and under the microscope, there was a papillary lesion, which was lined by respiratory epithelium and also stratified squamous epithelium. And it was slightly vascular. And there is an ulcerative area also, you can see on your right side. The corium was mostly bluish, which is composed with mixed inflammatory cells. And also there are some follicle-like areas also you can see under the lobar. In another area, there were it was lined by parakeratinized epithelium, and there are cystic spaces, cystic structures, some of which have eosinophilic material, and some of them are empty. And within that eosinophilic material, under the high power, there was a nucleus with prominent nucleoli. So this section is very characteristic for the disease condition. And now you must have come to the diagnosis if you're familiar with this kind of disease conditions. So this is the low power. So you can see the epithelium, and there are cystic cavities like areas filled within the connective tissue. So this way you can clearly see the mature and immature sporangium, some of which were eosinophilic and some others are basophilic, and some are having granular appearance. Apart from cystic-like areas, there was a foreign body type giant cells you can see in the block arrow. Here also there are some basophilic filled spaces as well as eosinophilic material filled spaces. So in this view, you can observe there are different stages of maturation stages. The small circle, the small sporangium is there. So it's an immature sporangium with eosinophilic unilamellar wall, and nucleus is also visible. And there is an intermediate sporangium with a bilamellar wall enclosing abundant immature endospores. There's a sporangium which indicated with an asterisk. So you can see there is two small endospores. So they are mature ones. So in some areas, there were ruptured sporangium, so which releasing the mature endospores, and here there will be a dense inflammatory infiltrate because of this rupturing. Mainly, we could see plasma cells and lymphocytes, and also there is an immature sporangium as well. So in this slide, so each sporangium can have the sporocytes can produce sporangium. So this is the sheet of this early or immature sporangium. So as I said earlier, there was a giant cell reaction. Under the high power, it is possible to observe these sporocytes within the giant cell. And also this patient was a neurofibromatosis patient, and close to the stalk area of the lesion, there were some spindle-shaped cells. But unfortunately, we couldn't do the S100 immunostain. So it could well be a nodule of neurofibroma, which is super infected with this organism. So the diagnosis is rhinosporidiosis. It's a pharyngeal one because which is very rare. Normally we can see in the nasal area, but to the oral and maxillofacial surgeons, it's a rare presentation because normally the ENT surgeons get this kind of biopsies. Sorry, they do this kind of surgeries, not OMF surgeons. So moving to the discussion, rhinosporidiosis is a chronic granulomatous disease caused by the Rhinosporidium zebrae, and it is endosporulating microorganism. This disease is endemic in India, Sri Lanka, and tropical areas of Africa and South America. Most commonly, it affects the nose, but other mucous membrane also can affect, like nasopharynx, oropharynx, conjunctiva can also be involved. And transmission occurs by bathing in stagnant ponds where animals also bathe. Patients usually present with reddish nasal mass, which is fragile and it bleeds profusely. And the diagnosis, which can be confirmed with the excisional biopsy, which showing typical sporangia in the tissues. Treatment is surgical excision, but it is necessary to do cauterization because to prevent recurrence. And Dapsone has been tried in a few cases to reduce the recurrence rate, but still it is not confirmed. Most patients require multiple surgeries because it has high recurrent rate. And to conclude that, I would like to thank Dr. Kamila Vijayalagge because the OMF surgeon of Puliapidia. And also thank you for giving this opportunity, and thank you very much.
Nice. Very interesting case. Beautiful histopathology. Thank you very much, Dr. Samadara. Thank you. Dr. Tilak?
You are muted, sir.
Yeah, it's a good case. As Samadra correctly said, this is a disease endemic mostly to India and Sri Lanka, actually. If you look at the prevalence, the highest prevalence of rhinosporidiosis is in Sri Lanka and India. And the World Authority of Rhinosporidiosis is in Sri Lanka. Professor Arsa Kulratne, he has written a textbook, a big textbook on rhinosporidiosis. And I was fortunate enough to be involved in research in rhinosporidiosis. For the first time, we published the cell-mediated immunity in rhinosporidiosis about 25 years back with Professor Arsa Kulratne. Fascinating disease, but if those who are interested to read, I think I advise you to look at that book. You can't find that much of details anywhere else in the literature, in libraries. The fascinating disease, yes, this is I have not seen pure oral presentation of rhinosporidiosis. I have seen a few cases again presenting in the soft palate as soft palate nodule. That is the closest that a dental or OMF surgeon can get. But as Samara correctly said, the nasal area is the commonest area, but it can, rarely you can get in all other areas as well. But that manifestation is exceptionally rare. And a lot of work, if you just put the word Arsa Kulratne, you will find a lot of articles published on this subject.
There are no questions from the audience on YouTube. So, do we wrap up the case or do any more thoughts on this?
I think we can move on. No more comments.
Yes, there are no comments. Okay. Thank you, Dr. Samadra. So our next presenter is Dr. Kavita.
Am I audible?
Yes, you are.
Good afternoon, all. I'll be presenting a case of unicystic ameloblastoma and its clinical issues. A 14-year-old male patient presented with painless swelling in the right corner of the mouth for the period of 1 month, he had a history of injury during bicycle ride 2 years back. On clinical examination, we found a 3.5 to 2.5 centimeter swelling in relation to 4-3 region. A unilocular radiolucency was found between the roots of 4-3 and 4-4. The most probable differential diagnosis for unilocular radiolucencies of anterior mandible in young patients will include radicular cyst, adenomatoid odontogenic tumor, amyloblastoma, odontogenic keratosis, dentigerous cyst, followed by calcifying odontogenic cyst, ossifying fibroma, central giant cell granuloma, or it could be even idiopathic bone cavity. We observed buccal cortical plate perforation with yellow serosanguinous fluid and cholesterol crystals during cyst enucleation. And we received a cystic bag attached to 4-3 and 4-4. The cystic bag was separated from the teeth and divided into two halves, one half of which was processed. Microscopically, we found thin non-keratinized stratified squamous cystic lining epithelium associated with fibroblastal connective tissue capsule and a flat epithelial connective tissue interface. The epithelial lining, cystic epithelial lining, showed palisaded basal cells, predominantly columnar with hyperchromatic nuclei. Stellate reticulum-like cells were present in the superficial layers. And there was also a focus of pre-amyloblastic changes in the connective tissue capsule. So with this, we narrow down to a differential diagnosis of dentigerous cyst with pre-amyloblastic changes, odontogenic keratosis, or it could be unicystic amyloblastoma. These pre-amyloblastic changes made us to get back to the retained tissue specimen, and there we found a focal nodular thickening in the retained tissue bed. So again, we processed the entire tissue specimen, and there we found islands of amyloblastomatous epithelium in the connective tissue stroma. Predominantly, it was in the plexiform pattern with strands, cords, and network of amyloblastomatous epithelium bounded by cuboidal and columnar amyloblast-like cells with stellate reticulum-like cells in between the cords. Focal areas also showed a follicular pattern, few follicles with peripheral layer of columnar cells exhibiting reversal of polarity, and central stellate reticulum-like cells were present. So all these features, this case microscopically had a cystic lining epithelium and also odontogenic amyloblastomatous epithelial islands within the connective tissue capsule, which made us to arrive at the final diagnosis of unicystic amyloblastoma with plexiform and follicular mural proliferations. Moving on to the discussion, according to the 2022 WHO 5th edition update on odontogenic lesions, unicystic amyloblastoma is described as an intraosseous amyloblastoma with a single cyst cavity. The essential feature is a single cyst and amyloblast-like epithelial lining. Luminal and mural extensions for subtype diagnosis is one of the desirable features. It's a variant of amyloblastoma, first described by Robinson and Martinet in 1977. 50% of the cases occur in the second decade of life, and greater than 90% of the cases involve the mandible. Most commonly associated with impacted tooth, of which third molar is frequently involved. The patients often complain of a painless swelling, and radiographically, a unilocular appearance is seen. That could be pericoronal, periapical, interradicular, and occasionally multilocular presentation can also be present. So Ackerman and Philipson subgroup unicystic amyloblastoma based on the microscopic features as broadly into three categories: luminal, intraluminal, and murine variant. The luminal variant will show that the tumor is confined to the cystic lumen alone. In intraluminal variant, the nodular proliferation of tumor cells extend into the lumen, mostly in a plexiform pattern, and so it's also called as plexiform unicystic amyloblastoma. In mural variant, invasive violence of amyloblastomatous lining epithelium or islands, be it follicular plexiform pattern, can be found within the connective tissue capsule. Accordingly, the treatment is given to the patient because the luminal and intraluminal variants are less invasive, less aggressive, can be treated conservatively, unlike the mural variant, which is more aggressive and has to be treated like solid amyloblastoma. So to give a brief overview, unicystic amyloblastoma usually occurs in younger individuals with a unilocular radiographic presentation, less invasive, has a lower recurrence rate, treated conservatively, unlike the multicystic embryoblastoma, which usually occurs in third to seventh decade of life. With a multilocular radiographic appearance, it's more invasive, has a high recurrence rate, and hence has to be treated with radical surgical procedures. We also find that BRAF V600E mutation and calretinine overexpression is common in unicystic amyoblastomas compared to multicystic amyoblastomas. In multicystic amyoblastomas, RAS and fibroblast growth factor receptor 2 mutations are found. In comparing with dentigerous cyst, we go by the Vickers-Gollins criteria, which states that ameloblastic lining composed of columnar basal cells in palisading pattern with vacuolated cytoplasm and hypochromatic nuclei polarized away from the basement membrane will differentiate unicystic ameloblastoma from any other cystic lesion. Besides the histopathological criteria, there is an upregulation of PCNA and Ki67 in unicystic ameloblastoma compared to dentigerous cyst. Dentigerous cyst shows a positive reaction for lectins, which is not found in ameloblastomas. And dentigerous cyst is managed more conservatively, just like the luminal and the intraluminal variants of unicystic ameloblastoma, whereas here the mural variant is treated like solid ameloblastomas more radically. So this is again a reiteration of Vickers-Gollins criteria. Now, coming to the treatment of unicystic ameloblastoma in children and adolescents, it's complicated only because of these three factors. There is continuing facial growth and different bone physiology, more cancellous bone, increased bone turnover, and reactive periosteum. There is presence of unerupted tooth. We do find a difficulty in initial diagnosis. A systematic review was conducted in 51 cases of unicystic ameloblastoma in children in 2014 by Sentau and et al. And they found that almost a majority of the cases were treated by enucleation and curettage. However, the recurrence rate was also high with enucleation, that is around 29.4%. However, conservative treatment has to be preferred for younger age group patients as it offers a better quality of life. To summarize, ameloblastoma in children and adolescents is characterized by an average age of 13.6 years. It predominantly affects males with a predilection for the mandible. Serial sectioning of cystic lesions will help to identify unicystic ameloblastoma and its mural components, which will otherwise be diagnosed as odontogenic cyst. The treatment plan will mandate subtyping of unicystic ameloblastoma to decide to proceed with conservative or radical surgical procedure. Recurrence rate, which again varies with different types of ameloblastoma, determines the effectiveness of treatment. Conservative treatment with long-term follow-up can be preferred for treating unicystic ameloblastoma in children and adolescents to avoid significant facial morbidity. I thank my mentor, Professor Dr. Ranganathan sir, for guiding me through this presentation. I thank all my colleagues and my sincere acknowledgements for the members of Asian Society of Oral and Maxillofacial Pathology for providing this platform to present this case and for organizing the clinical pathological conference. Thank you.
Thank you. Thank you, Dr. Kavita. Thank you very much. Dr. Tilak?
Yes, this is a case that the young pathologists can learn something. This shows how important your macroscopic description and macroscopic examination is. Now, you are lucky in this case, you found a single focus of ameloblastomatous proliferation in the cyst wall. If you did not have that, you would have completely missed the diagnosis of ameloblastoma. Again, it tells us, how important the macroscopic examination of a cystic lesion. Now, this to me looked like the significant unicystic ameloblastoma that shouldn't have been missed at the first, the cut-up, or whatever you call grossing. So therefore, whenever we encounter with a cystic tumor, cystic lesion, the clinicians query odontogenic cyst, I think we have to feel inside very nicely or even the tiniest elevations, the nodular areas. And those are the areas where we should do this sectioning if we are not doing serial sectioning to start with. In some countries, in some pathology departments, I know the whole cystic lining is serial excised, and you get the slides of the whole specimen. But in most places, when you have a cystic lesion, you don't do so. You get one section. So when you take that one section, then you have to be very careful to take it from the very proper area. Yeah. So it's again, if you find even unicystic ameloblastoma with the first section, if you have remaining tissue, I think it is mandatory you go back to the specimen and serially slice the whole thing in order to exclude possible mural extension or even conventional ameloblastoma elsewhere. So this is a good case to understand or learn that lesson, which is very, very important.
Thank you. Thank you, Professor.
Thank you, Dr. Hilla.
So we have some questions. So the first one is from Dr. Sridevi. In your opinion, does presence of foamy histiocytes in a wall of an inflamed cyst rule out unicystic ameloblastoma in cases where the lining is not exactly specific?
We first go for the key features of unicystic ameloblastoma. So, presence of foamy histiocytes.
Yeah, it's let me answer that. Yeah, let me answer that. Actually, you need the criteria of a unicystic ameloblastoma. Foamy histiocytes are usually a component of inflammation. And normally when you have inflammation, what happens is the cystic lining is lost in those areas. So you may not see the typical features. You may need to go to areas which are not inflamed or do not have signs of inflammatory infiltrate. So in short, histiocytes indicate an inflammatory component and really does not have any bearing on diagnosing it as unicystic or otherwise. So because these are totally two different things we're talking about.
Yes, it's important. I think again the trainee pathologist should know the differential diagnosis of unicystic ameloblastoma, especially the luminal type, includes inflamed dentigerous cyst and radicular cyst. Now, sometimes it is impossible. If you look for reverse polarity areas in an inflamed cyst, you may be able to find areas similar to that. Even inflamed odontogenic keratocyst, when the keratin is lost completely, it can mimic the appearance of unicystic ameloblastoma due to the keratin is lost completely, and B, the epithelium can start proliferation. You might not see that 5 to 9 cell or 10 cells thick regular the parakeratinized epithelium like in classic odontogenic keratocyst. Instead, you will see a little bit of spiky ridges, etc., similar to what you get in unicystic ameloblastoma. So one has to be very careful. Some people think subepithelial hyalinization is helpful. Yes, it is, but sometimes you can get that in dentigerous cyst also. So, therefore, if it is not classic cystic ameloblastoma, you've got to be careful not to misdiagnose it as a radicular cyst or inflamed dentigerous cyst or even inflamed odontogenic keratocyst.
We have one more question from Dr. Saikat. Her question is: does radiographic evidence of tooth being pushed by radiolucency suggest more towards unicystic ameloblastoma than a cyst?
Again, I go by what Professor has told. We need to go by the key microscopic diagnostic criteria. This occurs in the scenario of a tooth being pushed because of a cyst is seen in many lesions, many entities. So that is not
the only thing which, and what should I say, a divergence of the root association with the cystic swelling indicates that it's growing by slow expansion. That's the only inference we can make, and need to be very careful with radiographic features. And it shows that it's an expansile growth, which we normally don't see with odontogenic keratosis. But I have seen that in a couple of dentigerous cysts with OPC-like areas. So just going exclusively by radiographic findings is something you want to avoid. In fact, in this particular case, there was no incisional biopsy done. The clinician thought with the history of trauma and fall, it's probably an inflammatory cyst, and they got the entire excised specimen with the diagnosis of inflammatory cyst. So there was no incisional biopsy done. So radiographs are good if you club it with the clinical and histological features, but I would never ever use it except in very few cases as the sole basis of your final diagnosis. It really doesn't work that way.
That's true.
Yeah,
We have
that's
one more.
correct.
Sorry. Yes, sir. Please go on.
No, that's correct. The radiological findings are important. You can come to a differential diagnosis with radiological features, but to come to the more the close the definitive diagnosis is difficult. Dentigerous cyst, some subtypes of dentigerous cyst you perhaps can, when the whole crown is circumscribed, the circumscribed type or circumferential type, you may be able to, but the lateral type where the tooth is almost pushed like towards one end, so that is very difficult, if not impossible, to differentiate radiologically from unicystic ameloblastoma. And you can get keratocyst with dentigerous relationship. You have the nice dentigerous looking epithelium toward the cementary enamel junction, but from there later on you get keratocystic epithelium. So that has also been described. So you have to be careful about it as well.
So we have one more question from Dr. Saikat. It's in case of mural variety, should the reporting pathologist put a word on aggressive management of the case in the report?
Oh yeah, definitely. Definitely, it helps to work with the clinician, and I think most of the clinicians we work with, the moment we say unicystic, they ask us what we should do next. So we basically dichotomize into two groups, like what Dr. Kavita had said, restricted to the lumen, treated conservatively. Any mural involvement or mural proliferation, treat it like an ameloblastoma. Whatever protocol your center follows, treat it like that. We consider that as an ameloblastoma. Having said that, it becomes a little bit tricky when it happens in a child or in an adolescent, because we're talking about vital structures and things like that. So what I normally do is I tell them, whatever protocol your center has for doing it as an ameloblastoma, please follow that. That's it. So that usually works for them.
Yes, his question about whether pathology should mention something in the biopsy report. Yes, it depends. In different countries, people do in different ways. But I suggest, if you are a young pathologist, when you start your career, I think it is good to have a comment at the end. But in my practice, I usually put comments for various the entities. So it is better to say, the within brackets at least, this tumor may behave like a conventional ameloblastoma when you report a mural entity. So there is no harm. Then at least, when surgeons take decisions without any MDTs, that is the case in a lot of developing countries. Better to alarm them that you are not looking at just a unicystic ameloblastoma.
Yeah, I agree, Tilak, absolutely. Absolutely. But what we have a problem is a lot of times we never get an incisional biopsy. We straight away get a conservative excisional biopsy of the cyst. And the moment you put in ameloblastoma, the surgeon finds it really difficult to explain to the patient how that happened because they can't go back in and. But fortunately for this case, what happened was they had marsupialized it and put some carnoy solution and classic aggressive cyst management. But I totally agree. We need to make a comment at least saying that should be treated with respect like an amyloblastoma, as far as the management is concerned.
Very true. I think that adding, like both of you said, that adding a note at the end always helps clarify so much. We have one more
But
question.
it can be a little bit
Sorry.
tricky in certain contexts, actually. That's the problem. It depends upon,
That
once
is true.
again, what sort of work you have with the interaction you have with the surgeons, actually. Okay, please go ahead. Sorry.
That's true. No, no, that's okay. So we have Dr. Suchitra. For diagnosis of dentigerous cyst, is it not necessary to have lining attached to CEJ?
Um, yes, fine. That's absolutely correct. But what will happen is, in real practice, you will see that you will get a lot of cysts post-inflammatory with perifolliculitis and things like that. So, in fact, what I normally train my postgraduates is, uh, if you have a classic radiographic appearance inside, a lot of times we give dentigerous cyst even without a cyst lining. Even when the cyst lining is totally messed up because of inflammation, uh, we give it as a dentigerous cyst based on clinical and radiological features, along with the histological features. So yes, if it is attached to CEJ, it is helpful. But no, most of the times you don't get a classic specimen like that along with the tooth. Yeah,
Very true.
yeah, Tilak.
Okay, shall we go on? Sir, Dr. Tilakratna, you have any addition to that?
No, that's fine. Yes, as Ranga said, I think they're very important to get the clinical and radiological information. If those things are not there, if uh, the cyst wall is inflamed, I never give a bottom line diagnosis. My bottom line would be these histopathological features are consistent with either inflamed dentigerous cyst or radicular cyst in the appropriate clinical context.
That's
We pass the the ball to the clinician to decide
Yeah,
without we getting into trouble.
that works.
always good.
Thanks, Tilak.
Yes. Okay. Yeah. Thank you, Dr. Kavita. We'll, I think, go on with our next presentation, which is by Dr. Erica. Right. Dr. Erica, you can start.
Okay, yeah. Hi, very good afternoon, everyone. I'm Dr. Erica He, a fourth-year postgraduate student in oral medicine and oral pathology from University of Malaya, Kuala Lumpur. So I'll be presenting a case today, which is a rare tumor in a HIV-positive patient. So this is a case which was received in our department as a second consult case. So this is a case of a 25-year-old male who presented with swelling on the right maxillary region for about 10 months duration. And the swelling measures about 4 times 4 centimeter and is associated with pain. And besides that, the patient also had bilateral blurring of the eyes and diplopia and palsy of the left cranial nerves, particularly the cranial 2, 3, 4, and 6. And additional medical history also showed that our patient was diagnosed with HIV 3 years ago. So this is a CT scan which shows a lesion on the right maxillary area and eroding into the underlying zygoma with communication with the right anterior sinus wall and also the lateral and inferior orbital wall. And this other view also shows that it seems to be an intracranial lesion on the left side. So incisional biopsy was performed by the clinician from the right maxillary swelling. And this shows the microscopic features of the biopsy specimen and showing multiple pieces of soft tissue. And microscopically, these are the features. So low power, we can see it's a highly cellular tumor composed of spindle cells, which are arranged, you can see in some areas in short intersecting fascicles. And also in some areas, it appears that it's haphazardly arranged. And the stroma is highly nice. And the cellular features you can see shows hyperchromatic with blunt-ended nuclei mostly, and also it shows some very mild pleomorphism. In some areas also, the tumor have this the cells have this rounded primitive appearance, and also there are presence of a few mitosis as shown in the arrow. However, there are no necrosis found throughout the biopsy lesion, the specimen, sorry. And there are multiple slit-like vascular channels seen as well. Okay. So because of the histological appearance and the clinical features, there are few differential diagnoses for this case, and it's mostly spindle cells because of the blunt-ended nuclei appearance. So leiomyoma, smooth muscle tumor are high up on the list of differential. However, in addition with the patient's history of HIV positivity, other tumors that need to be considered include colpocytoma, EBV-associated smooth muscle tumor, and mycobacterial spindle cell tumor. So immunohistochemistry studies were done, and it shows that the tumor cells are diffusely and strongly positive to smooth muscle actin, and it shows focal positivity to H. caldesmon and desmin. And additional panel of immunohistochemistry were also performed, and it has helped to rule out most of the differentials. As here you can see, so Kaposi sarcoma is ruled out because CD31, 34, and HSV8 were negative. And mycobacterial spindle cell tumor, which are composed of spindle-shaped histiocytes, are also excluded because of negativity to CD68 and S100. And solitary fibrous tumor also ruled out because negativity to CD34. And also the collagen features are also not appropriate for this diagnosis. And peripheral nerve sheath tumor such as schwannoma or even MPNST are also ruled out because first this absence of the nuclear morphology of a nerve lesion, and also S100 and SOX10 are negative. And synovial sarcoma and spindle cell squamous cell carcinoma also rule out from negativity to epithelial markers, as well as melanoma also excluded, as all the markers for melanocytic tumors are also negative. And based on the immunohistochemical findings, so these are we end up with these differential diagnoses. So at this stage, what do you think is the diagnosis for this case? But in view of the immunohistochemical findings, the histological findings, and the patient's history, I'm sure all of you have the diagnosis already. So EBER in situ hybridization was done, and it shows diffuse nuclear staining. So we end up our final diagnosis is EBV-associated smooth muscle tumor. So a bit of discussion on this lesion. So EBV-associated smooth muscle tumor. So in this, the latest version of in the 5th edition of the WHO classification of head and neck tumors. So this entity was listed out separately from leiomyosarcoma because of its relatively indolent biological behavior, and it has very low potential to metastasize. And it affects both male and females equally, and it can be found in a wide range of age in patients. And it's also a predilection for patients of Asian ethnicity reported. However, the most important clinical features is that it normally occurs in patients with a background of immunosuppressed patients. And also a time lapse from the onset of immunosuppression until the tumor presentation is also reported. So EBV-associated smooth muscle tumor is frequently multifocal. Up to 3/4 of the tumors are found to be multifocal, and it can be either synchronous or heterochronous. And Hussein et al., they reported some variation in the site preponderance among the different clinical subsets of tumor. And this is a rare lesion in the head and neck. However, it has been reported in the oropharynx, larynx, eye, tongue, and palatine console, and even sinus area. And the mechanism of the role of EBV infection in the tumor is not fully understood yet, but it appears to be related to the interaction between EBV and CD21, which is EBV receptor on smooth muscle cells. However, studies have found that CD21 is not expressed in all tumors, especially those of post-transplant patients. And EBV type 3 latency pattern has also been suggested to be involved, where there's activation of the AKT-mTOR pathway, which play a significant role in smooth muscle proliferation. So the main diagnostic pitfalls for this case is that for this lesion, we know it's smooth muscle in origin, but it does not conform to the characteristic features of leiomyoma or leiomyosarcoma because it can have multiple mitosis, which is usually absent in leiomyoma, and however, it's not very pleomorphic, and there's absence of necrosis as usually found in leiomyosarcoma. And also in this lesion, as the cells can often have the primitive rounded cell appearance, and also there can be presence of numerous vascular channels in some cases, and like one may think of vascular lesions in the differential. And HIV positive cases may show higher mitotic activity or necrosis, and because of this, sarcoma may also be in the differential. However, I think for this case, the most important is that the history of immunosuppression will help in the diagnosis. Thus, in cases of spindle cell tumors or smooth muscle tumor in immunocompromised patient, it's always advisable to do a test or in situ hybridization for EBV whenever possible. So the most common management for EBV-associated smooth muscle, surgery is the most common therapy reported. However, there are other therapy also used by clinicians, including radiotherapy or chemotherapy. And the prognosis is mainly dependent on patient's immune status, and it has a low metastatic potential and also low recurrence potential. So in conclusion, EBV-associated smooth muscle tumor, they are very rare tumors in the head and neck region, and this entity should be considered in the list of differential, especially when there's a smooth muscle tumor or a spindle cell tumor arising in immunocompromised patient. And the diagnosis is based on the clinical history with the histopathological findings and immunohistochemistry and in situ hybridization studies. So special acknowledgement for Dr. Fairuz for providing the case, clinical photos and details of the case, and also for Professor Tilakarane for our consultation and his guide in preparing this presentation. And these are my references, and thank you.
Thank you, Dr. Erika. Very interesting case, very well presented. Thank you very much. I have just one question. It was HHV8 positive, is it? The lesion was HHV8 positive?
No, it's negative. Sorry.
Oh, negative. Oh, I thought you said positive. Okay.
Negative.
Because there have been, reports of EBV-associated Kaposi's actually. This is sort of because they all belong to the same family essentially, and there are certain pediatric cases where you can get Kaposi's sarcoma, which are also EBV positive. So that's okay, fine. HHV8 negative. All right. Thank you.
We have one question. Let me just add that. So Dr. Basavaraj said, is it seen in only HIV patients or even on patients on immunosuppressive drugs for organ transplants?
Yes, I think it is possible to get in any immunocompromised patients, immunosuppressive patient, but it is mostly seen in HIV positive patients. As Erika correctly said, only this time we included this in the WHO classification. And you need to remember three things are important. They are the essential features without which you cannot diagnose EBV positive smooth muscle cell tumor. HIV positivity, I think other immunosuppressive you can't theoretically you can't say no, but HIV positivity, smooth muscle differentiation, although smooth muscle differentiation is there in immunohistochemical results, HNE may not show the characteristic smooth muscle differentiation everywhere, because there is another cell population which is not matured properly, so undifferentiated looking. 2, 3, it should be positive nicely, like our case, it should be nicely EBV positive.
Yeah. Yeah. If I may add to that, I think Dr. Erika, you had mentioned that it's either 1 year or 18 months or 18 years after transplant
Yes.
or HIV positivity. I think you mentioned that in your slide. So I think it's post-transplant or HIV infection. So.
I think there's a follow-up with that. Does interferon have any role in management? Any thoughts on that?
No, I'm not sure, because we have handled the EBV positive cases, and usually if you correct the immunosuppression, we can usually bring EBV under control, and of course, treat the local tumor. So that actually helps. But correcting the immunosuppression along with the local regional treatment of the neoplasm is usually sufficient. But if it's interferon as a part of the general management of the immunosuppression, may have a role.
Yeah, now you have to remember this. The literature is limited. Even the time that we were doing the WHO Blue Book, literature was not great, but the people try different modes of treatment. But the recommendation at the moment is conservative resection without going for radical resection. And of course, the prognosis of this tumor depends on the immune condition or immune status of the patient. If the patient is severely immunocompromised, the patient will develop multiple lesions elsewhere. So if it is the patient with transplant therapy, I think it is advisable to try and reduce the immunosuppressive dose. So that is the recommendation at the moment for this tumor.
Thank you all. And thank you, Dr. Erika. I think we can go to the next case. The last one is by Dr. Rasika. Yes, Dr. Rasika, you can start.
Yeah. I'm Rasika Ekanayaka, consultant oral pathologist from Sri Lanka. My case for today is a radiolucency in the body of the mandible. So let's see what it could be. When it comes to the history, a 58-year-old female presented to the Department of Oral and Maxillofacial Surgery with a progressive swelling in the right side mandible of 5 weeks duration. Furthermore, the patient reported a 3-day recent history of pain associated with the jaw swelling. Her past medical, dental, and surgical histories were unremarkable. The extraoral examination, as per this photograph, the side view, which revealed a diffuse, non-tender, bony hard swelling involving mainly the right side mandible, measuring about 16 to 4 centimeters in its greatest diameter. The front view actually showed a significant facial asymmetry. However, there was no cervical lymphadenopathy. The mouth opening was normal. Intraoral examination revealed a well-defined firm swelling in the right side posterior mandibular buccal sulcus in relation to 46, 47, and 48 region, measuring 5 into 3 centimeters in size with no apparent mucosal changes. Swelling was hard in consistency and non-tender on palpation. Radiological findings as per the lateral oblique radiograph of right side mandible, a multilocular radiolucent lesion with relatively well-defined margins was observed. So based on this history, clinical and radiological findings, a provisional diagnosis of ameloblastoma in the right mandible was considered, along with the differential diagnosis of odontogenic keratocyst. Therefore, with that knowledge, an incisional biopsy was performed under general anesthesia, and the specimen was submitted for histopathological analysis On gross examination, the specimen consisted of multiple fragments of cheesy-looking fibrous tissues, white in color, measuring 20 into 15 into 10 millimeters in size. So this is the histopathological, the characteristic tumor view. It consisted of thin strands and small nest of epithelial cells, and the prominent feature was the hyalinized tissue. This showed the same thing in high power view. And this one, the high power view, again highlights the epithelial cell arrangement into the thin strands and small nest. However, please note lack of mitosis and significant cytological atypia. However, there were several foci of central comedonectite necrosis within the epithelial cell nests. And most importantly, there were presence of weight ductal differentiation was observed, and together with a few foci of calcification within the tumor. So therefore, the initial diagnostic panel for the immunohistochemical markers used was CK7, CK20, and CK19. Tumor cells showed a strong and diffuse cytoplasmic positivity for CK7. CK20 and CK19 were negative. So once the CK7 and CK20 expression profile was established, additional organ-specific markers were performed. However, considering the limited availability of immunohistochemical markers currently in Sri Lanka, a minimal set of markers for carcinoma identification were evaluated. This photograph shows a scattered nuclear positivity with estrogen receptor, ER immunostain. And again, this one, a similar scattered nuclear positivity was observed for the progesterone receptor. TTF1 was negative. And the tumor, for the subsequently performed HER2, the tumor was immunonegative for that one. So the histopathological features and the immunoprofile of this case were more suggestive of a metastatic adenocarcinoma of breast origin. And with that knowledge, systemic investigations and workup were therefore recommended. So the subsequent to the histopathological diagnosis, the patient was referred to the general surgery unit, where an ultrasound scan of both breasts and axilla were performed together with a CECT of chest, abdomen, and pelvis. It reported a lesion in the right breast extending to the nipple and the skin, measuring 3.5 into 2.7 into 1.9 centimeter with enlarged lymph nodes in right axilla. Both these findings serve to confirm the initial histological assertion of presence of a primary breast adenocarcinoma. So no other distal metastases were identified in the CECT. The subsequent ultrasound-guided FNUC reported a C4 lesion in the right breast. Histopathological evaluation of a true-cut biopsy from right breast tissue revealed an invasive breast carcinoma of no special type, and therefore a prompt referral was arranged to the oncology unit for chemotherapy. Let's move on to the discussion. Metastases to the orofacial region are uncommon and comprise approximately 1% of all oral malignancies. The jaw bones, particularly the mandible, and more frequently affected are more frequently affected than the oral soft tissues at a ratio of 2:1. The attached gingiva is the most commonly affected soft tissue site. Most metastatic tumors to the orofacial region are seen in patients between 5th and 7th decades of life, and there's no sex predilection in jawbone metastasis. However, an average of male to female ratio of 2:1 is reported in oral soft tissues. The most common primary tumor sites for orofacial metastasis, when it comes to male, it's lung, kidney, liver, and prostate. For the females, it's breast, genital organs, kidney, and colorectal. Lung is the most common primary site for tumors that metastasis to oral soft tissues, while breast is the commonest primary site for jawbone metastasis. In majority of the patients, primary tumor is known at the time of diagnosis of the metastatic lesion. However, as per the scenario of the present case, in about 23% of cases, the metastatic lesion in the orofacial region is the first indication of an undiscovered tumor at the distant primary site. Let's move the discussion. If you discuss a little about the breast cancer, it is the most commonly occurring cancer in women, both in the developed and less developed world, and the world's most prevalent cancer overall. Breast cancer is the most common cancer among females in Sri Lanka as well. Highest incidence is seen among women of 60 to 64 years age group, and the female breast cancer incidence in Sri Lanka is increasing approximately 4% per year. So metastatic breast carcinoma most often reported in lung and liver, bone, lung, and liver. When affecting the oral cavity, the metastatic deposits from breast cancer preferentially spread to jaw bones. In women, actually, 40% of jawbone metastases originate from breast, compared with 25% of soft tissue metastases. Metastasis to the jaw bones is a late complication and frequently a part of generalized spread with associated multiple coexistent metastatic deposits. And metastasis to the mandible is usually associated with a poor overall prognosis, and the majority of patients die within a year of detection of the metastasis. Distant metastasis is the principal cause of mortality among breast cancer patients, despite their relatively high 5-year survival rate. And the management of metastatic breast carcinoma of the mandible, therefore, is primary palliative. So in conclusion, though rare, it is important to consider the distant metastasis in the differential diagnosis of a jaw lesion, even if the presence of primary tumor is not known at the time of detection of the jaw lesion. So these are my references for the case, and thank you for giving me this opportunity. Thank you all.
Thank you, Dr. Rasika. Very interesting case. Dr. Tilak?
It's a very interesting case, Rasika. Now, with the histology of the gingival lesion, what was your differential?
So actually, it was a bone lesion. So like there was the multilocular radial recency. So they have
Yeah. With that, what was your histo?
So if you what I actually thought is like if it's going for the odontogenic thing, it could be something like COT. Or else like I could, since it was not sure because the features were not classic for the COT only, that I put the immunos actually, and because of this vague ductal differentiation as well.
Was ductal differentiation very prominent or just few and apart?
Single foci, yeah. It could be like for the tumor degeneration of tumor cells also could be have the similar appearance. So, but yeah.
That's
Did
wonderful.
you do a PET scan? PET scan was done.
Not actually, I'm not aware of the if being done in the oral OMF unit as actually. I don't know whether it was done in the surgery unit after the chemotherapy, like before they started the chemotherapy.
Okay.
Yeah,
it was not actually. It's not aware in our center. I'm from Goal. It's not aware in our center, but if they have like sent the patient to the main center in Colombo, probably they would have done, but I'm not aware. So.
Thank you.
But this is clinically this is a slightly strange case because usually when before breast cancer come to oral cavity, usually most of the time it should have been diagnosed the breast cancer, but it's not the case in this one. What is the T stage of the breast cancer?
Yes, I can do this.
Sorry?
I think the voice is dropping off.
Yes, there's a problem with the voice there.
Okay.
But it's good anyway. It's a good, clever diagnosis. Actually, it's not a typical breast cancer according to what I saw in the history of the gingival, the oral lesion. When you have slight ductal differentiation, a lot of sclerosis, even things like sclerosing mucoepidermoid can be in the differential. But it's good. But the cellularity is very less in this tumor, right?
Yeah. Yeah.
Yes, so it was like the prominent feature was the hyalinized tissue actually. The prominent feature, like it's throughout, it was very hyalinized. So, and the cellular features were very less to assess.
Were there any features to suggest or for you to suspect whether it's a sclerosing odontogenic carcinoma at any point?
I was going to ask that, Tilak, actually.
So the
Yeah.
thing was, can you hear me?
Yes, yes, it's breaking, but we can. Yeah. Okay, good case.
I think there's a
All right.
connection.
Yeah, her voice is breaking. Okay. Yes. Thank you, Dr. Rasika. I think that was the last case we had. Now I will hand it over back to Dr. Simarpreet to do the needful.
Thank you, Dr. Mandana. And that indeed was a great session. Great cases, nice presentation, and great comments from the experts, and obviously great insights from the people who joined in. And now we come to the felicitations. And on behalf of the Honorary President, Dr. Ranganathan, we'll be giving off the certificates, and it's going to be serial wise. So the first certificate is for Dr. Lavanya C from India. The next certificate is presented to Dr. Feroz Abdul Rahman from Malaysia. Thank you, Dr. Rahman. The next presenter is Professor Samadara Sirivardne from Sri Lanka. Thank you for the excellent case and thank you for participating. Thank you, Dr. L. Kavita, for submitting an interesting case. Dr. Erika Hai Pei Wen from Malaysia, thank you so much. And last but not the least, Dr. Rasika P. Ikaninarika from Sri Lanka, thank you for submitting the case to the Asomp platform and making today's event possible and a great success. And thank you, Dr. Mandana Donahue, for stitching it all together for us and for seamless not only moderation, but also giving us the platform and making today's seminar a success. Thank you, Professor W.M. Tilak Ratne, the advisor from Asomp, who gave the expert comments and whose vision, it was the vision of the advisors and the president to have the Asomp series, and it's finally happening. Thank you so much for being there today with us. And we acknowledge our own honorary president, Professor Ranganathan K, for sparing time and for being the driving force behind the SOMP series. Thank you so much, everyone. Now, may I request everyone, the participants, the experts, and the moderator to join us for a memory shot.
Just a second. I will add everyone in.
Just come in. Can't believe it's, yeah.
Did
So
we
we
get
want to
everyone? Yeah.
see, yeah, two. That's what I've been doing all these days. You're all there, and I'll just, just take the memory shot. Thank you, everyone. It was really a great Sunday afternoon. Thank you so much.
Thank you.
So
Thank
we
you,
meet,
everybody.
and just one announcement to everybody logged in. Please join or subscribe to the SOMP channel. That is the official YouTube channel of Asian Society of Oral and Maxillofacial Pathology. And we'll soon announce the dates for the second SOMP 2022 series. Thank you so much. Enjoy the rest of your Sunday. Thank you.
Yes.
Thank you.
Right. Thank you, everyone. Yes, please do remember to subscribe and also like this event. It was great having everybody here, and thank you. See you all. Bye bye.
Thank you. Thank you so much.